team for inviting us to present the project. So we are Critical Care Hope, and we provide the tertiary level care to the most remote locations through our mission in basically provide the expertise to the patients who are needed at the right care, right patient, right time. So what we do in the Critical Care Hope is we provide them the right care immediately whenever a patient needed. And the most important thing is we are a digital health ecosystem enabler. So when we say the digital health ecosystem enabler, so we take care of the patient. This is very, very important. We take care of the society, and we take care of the healthcare professional as well. We enable the periphery or the tier 2, tier 3 hospitals to take care of their ill patients, their critically ill patients within the their community, so that they cannot basically cannot travel to the big city or the urban city, and we can save that particular time and we can give them these services whenever they need it. So how we do it? This is basically, so firstly, the problem, why the Critical Care Hope is very important. So in a country like India, we have a huge country and we have a very less number of doctors. And to provide the services of a specialist doctor, which is even more very less numbers. So we have a command center in our in Jaipur, and there the intensivist or a critical care expert can coordinate, can intervene, can suggest at the time of treatment whenever a periphery hospital or a nursing home receives a patient in the hospital. So just to give them right amount of treatment, just to give them the right kind of suggestions or advisory, so we have a set mechanism of it. So what we do is, our aim is to enhance care coordination between stakeholders. So stakeholders are, one, the patient who need the treatment. Second, the doctor, the practitioner who is available in the tier 2 and tier 3. And third is the critical care home, from where we can suggest them, we can give them the backup, we can give them the support. So how we do it is the clinical care platform. We give them the multidisciplinary care in terms of like super specialty, neuro, cardio, gastro, whatever it needs. And this support basically comes in 24/7. So we have round-the-clock intensivists in our command center, and we can treat the patient as and when required. So decision makers, obviously in the tier 2 and tier 3 cities, they have the backup of those specialized doctors. So in terms of giving the treatment to the patient, it is very necessary to take the right treatment or the initial assessment to get the treatment trajectory very correctly. So we do it like in technology basis. So this is on your left, our command center, where the intensivist or a specialized doctor sitting and providing their expertise to the remote locations. On your right, our team in periphery hospitals, or we basically use it to say remote side. So we give them the commands, we give them the instructions. On the basis of that instructions, they follow the treatment. So this happens 24/7. This is our mechanism, integrated ecosystem. So on your extreme left, our command center. On your extreme right is the remote side, and how we connect them, how we amalgam the integration of the technology is in your just you can see in the middle of the slide. So bridging the gap with technology. So we have set of IoT devices which can connect to the different devices like monitors, ventilators, infusion pumps, and this data can come minute to minute basis on the command center, and we can set the trajectory for the patient wherever it needs. So in terms of providing the care on immediate basis, so whenever a patient deteriorating, so in advance we can get the notification that something is happening to the patient, and we can react to that immediately with the help of that technology.
Just to prompt, you're close to 4 minutes. Please keep a watch on the time.
Yeah, sure. Thank you. So this is our comparative analysis basically. So there are different companies who are running the shows, but how we are different from the others. So we are giving the services which is comprehensive. We are giving the complete manpower at the remote site, because we know the skilled manpower is also a very big problem in tier 2 or tier 3 cities, and the combination of technology, manpower, and expertise, when it comes together, then the only thing which can patient be benefit every time with the project. So this is basically our potential area, how we can impact the things. So in Rajasthan or the neighboring states, these are the analysis we have done, and we can give the services those areas where the healthcare is slightly not giving the appropriate services, or they does not have the capable thing to do. So this is basically on the other hand, we have impacted during our pilot project. So there are couple of hospitals. So before the Hope integration or the Hope association, they were at this stage, and we have increased the occupancy in just a numbers to those hospitals with the Hope association. So this is the adding value to volume. So there are many areas where different kind of illness is there. So when we say the different kind of illness, so in north of the Rajasthan, there is an area, Hanumangarh and Ganganagar. A lot of poisoning cases comes every day. So we go there, we have seen a lot of poisoning patients, and what we did is, so we have done only 2 or 3 different things. Like we have given them the protocols, what to do, how to do, and when to do. So this basically made one thing very clear, and we have, this is the study, what we have done. So in terms of paraquat poisoning or organophosphorus poisoning, so we have done the study. We have seen total 37 patients. So we have saved 26 lives. So it is very important to see that in paraquat poisoning itself, the overall mortality rate is more than 72%. And this is basically a social impact where a person who is living or who is residing in a tier 2 or tier 3 city, if the illness is costing them more than they earn, then it is very, very difficult for the entire family to cope up with. And for the treatment, they have to come across to at least 250, 300 kilometers away from their home, and they are spending money just for the treatment. So it is very, very important to give them the treatment within their economic system. This is just a glimpse of critical care Hope achievements. So we have done a case study combinedly with ISB, and it is basically published in Harvard Business Review. And we have recently got DX CII Award 2022. This is basically what we do is on constant basis, we do provide the trainings, the skills, so that the healthcare professionals can.
Just to inform you, the time is up. We have open for questions now. Jurors will ask questions.
Yeah, sure. Yeah.
Morning. Oh, good afternoon, New time.
Yeah.
I have a quick question, just maybe a comment as well. So the purpose of this is to link the tertiary center with an expertise. Your expertise will be available 24/7?
Yes, it is available 24/7.
Fine. And these will be connected through a software to the peripheral centers. This is what you mean.
So two things are there. One is audio-visual communication. Second is integrated technology, where we are getting the data.
Fine. And who is going to sponsor these? Who is going to pay the expert at the tertiary center, or the and who also is going to equip this periphery with the facilities? Are you going to help to initiate this facility, or the government or third party? How are you going to run it?
So there are two things, sir. First is initially the Apex Hospitals is the so Critical Care Hub is the 100% subsidiary of Apex Hospitals. So Apex Hospital is sponsoring all the project, and there are other two things. One, we associate with the hospitals on a sharing basis in the complete revenue system, and the second, that it is Critical Care Hub who offers and who basically set up all the things in ICU.
Thank you.
Thank you, sir.
Thank you. We open for next question.
Just quickly, one question from me. You said that you also provide manpower at the remote centers?
Yes, correct, sir.
And what kind of manpower is this? Because you say internist would be at your, the hub. So what is this manpower at remote places?
So basically, the idea was, sir, when we have intensivists in the command center, so it is very important to follow the instruction in a right way. So what we do is we provide two things. One is a doctor, which is a resident MBBS doctor, and our ICU well-trained nursing staff who can coordinate with the command center and follow the treatment instructions.
Okay, just quickly, last question from me. Like you said, I think it's been running for 2 years now, which I could see in your stats, which you show. Is it okay? And you mentioned you have 19 partners covering 131 beds as of now.
Yes, sir.
And you are more focused on Rajasthan, or you're pan-India at this point of time?
No, we are pan-India, sir.
You're providing the services pan-India.
Right, sir.
Given that you feeling that this is quite a success, don't you think the number of partners and number of beds is very small if the project is so, going on well? So it should have been, it should be multiplied by now. So is there any issues in terms of multiplying or, scaling this project in some sense?
Sir, the basic problem is in terms of peripheries. So every individual hospital or nursing home doesn't have more than 5 or 6 beds in an ICU. It is very unlike to the urban or a well-established city where ICU is 15 bedded, 20 bedded. So this is basically a ratio issue in terms of beds.
Okay. Okay, thank you. Thank you.
Thank you so much.
Right. I have a few questions. My name is Prabhakaran Durairaj. So I come from my cardiology experience and epidemiology experience. So I have a few questions. The first thing is, how did you evaluate your program? How do you know it is successful?
So we evaluate with one of the things, sir. So sorry, couple of the things. One, where our partner comes with us, associate with us, and give us the feedback. So this is the one mechanism where he is getting the patient and the outcomes. So we actually work on outcomes. And how we can calculate it. So as we have seen, you must have seen one slide where we have basically tried to see the comparison between before the Hope Association and after the Hope Association. we do collect the data from the remote side every time. So this is the one thing where we come across with the outcomes based system.
Right.
And another,
I'm not clear about the outcomes. That's why I'm asking, because the one thing which you're saying is a subjective provider assessment as an outcome. But more importantly, I would like to know how it has changed. Does it decrease the number of days spent in the ICU? Does it decrease the cost to the patient at the secondary care center? And actually, does it improve mortality or discharge alive for these patients? So that's one question. I'll come back to the second or third part of the question. So please answer this.
yeah. So for as far as your first question answer, so I'll give you one very short example. So whenever a patient treated in a city like Jaipur, the basically a ticket size of his or her bill is around ICU is 50 to 60,000. Okay, but on the other hand, if a patient is treating in the Bharatpur or getting the treatment in the Bharatpur, the ticket size is around 16,000 to 17,000, and these all the ticket sizes for the 2 to 3 days, not more than that. So one
No,
is the
but the ticket size would be dependent on what treatments you give. Like, for example, in Jaipur, you may be having a high-end ventilator, for example, whereas in Bharatpur, maybe you don't have the same equipment. Secondly, you might be doing in Jaipur more frequent, let's say, and just to give an example, arterial blood gases. You may be doing more ultrasounds, which you may not be doing there. And so those factors are costed in what happens in Jaipur. So I mean, that's cost is one factor, but I would like you to give some real examples of benefits to that patient. In fact, Mr. Jain was asking that it's only 131 patient. It's a small number. And I didn't see a business model of how you're going to scale it up across the country, because 131, even for assessment of outcomes, is extremely small. How do you say that this is really, game changer in terms of improving outcomes?
right, sir. So I think there are some miscommunication. So 131 are the beds, not the patients.
Okay.
And we have basically seen more than 18,000 patients.
Okay.
And in terms of the cost and the impact, what you are asking, so there are basically three things. So time, which is very, very important in terms of a critical ill patient. Travel, which is again a very means a very important thing. So transportation, so data says 41% patient dies during transportation. So in terms of transportation, we can save those patients who actually being treated in the peripheries, and we can save those patient lives in the peripheries as well. And the cost, what we have discussed, so that these costs, a ventilated patient cost is what we have seen in last 6 to 7 months in a periphery, not more than 35 to 37,000 a ticket size for a periphery center.
Right. So how do you provide training to people in the secondary care? I mean, do you provide them with a decision support system so that they can troubleshoot as and when a problem arises? Or because they require some basic training, even though you may be hand-holding remotely, they require some basic. What is the kind of training that you provide?
So in that case, sir, we have a bench strength. So whenever our site deploys, we doesn't do like that we just hire people and just give them the support to the remote side. No, we hire them in our center. We train them on a monthly or a 45 days schedule. So we have two schedules, basically a 1 month basic training schedule and for 15 days advanced training schedule. So on the basis of that, we provide the manpower at the remote site so that they can basically coordinate well with the command center team and follow the instruction as and when required.
Right. Okay. Thank you.
Thanks a lot, sir.
Thank you. Thank you. You almost had from all